So, South African universities and other institutions of higher learning produce between 1,200 to 1,300 medical graduates annually. This is grossly inadequate for the country's population. In fact, according to the World Bank, there's a ratio of 0.9 physicians per 1,000 people in the country. Not a pretty ratio at all. Now, the shortage of healthcare professionals is a big factor that does contribute to work-related stress and burnout. The question then becomes, how do we fix this? Here are the panelists that will help us answer that question. And of course, we welcome thoughts from yourselves as audience members watching this from home.
Dr. Nogokanya Kanyile, Vice President of Mental Matters. Dr. Yvette Lazarus, Specialist Physician and Rheumatologist, Morningside Mediclinic. Professor Terence Kamal, Founder Chairman and CEO of the Medical Expert Consulting Group. Dr. Paul Chaparelli, Chief Operational Officer, Clinical Services at the Tygerberg Hospital.
Good evening to you all. Nogokanya, can I begin with you? I mean, the obvious answer, or one of the obvious answers, let me not make myself an expert on the subject, is the fact that, we need more doctors and nurses. But of course, we don't produce nearly enough. And in the absence of the additional labor, how do we make the conditions less stressful for the existing workforce of healthcare professionals, in your view?
Good evening, everyone. And I just want to say thank you so much for bringing someone as young as me onto a panel like this. It's very rare, I found, for the voices of young professionals or junior doctors to be heard. And on a topic like this, we are seen as the workforce. Anyone can attest that interns in any hospital are the workforce. If you're short even 2 or 3 interns in any day or any department, it can actually cause a bit of a crisis. And we see this because there's so much responsibility put on these junior doctors, and we're expected to do so much with so little experience. And this is why we find the working environment particularly stressful for young junior doctors. We see that a lot of the teaching we actually get is from allied professionals as well as our other healthcare professionals, such as our nursing colleagues. We also see hardly ever see our consultants in the environment. So we get a lot of our teaching and direction from registrars who are studying specialists who are often very stressed, or medical officers who've been working in the system for a very long time and maybe demotivated themselves. And so when we ask for an improved working environment, what we're asking for is not that our responsibilities are laxed or that our workload is decreased, but that when things are organized in a situation where we are expected to do a particular amount of calls, that systems work in those places. Nurses are able to triage successfully and independently, referring to doctors who are able to work as medical professionals in that space. We're then able to send and call whoever we need to. And the problem is the system fails us here, because as junior doctors, we're expected to be porters, we're expected to sometimes be nurses, cleaners even sometimes. And that puts extra strain on us because we feel inadequate.
And I imagine that you'll say that you are not remunerated for the extra responsibilities that you are expected to do. But let me not poke any nails at any managers of hospitals, so get myself into trouble. But Yvette, to bring you in here and just to give us a bit of an experience or the color of your experience working in the healthcare space as a young professional also. What is an ideal, what have you found an ideal environment to be, and where have you not experienced this so far in your medical career?
Thanks, Fifi, and thanks everyone for allowing me to chat to you. I spent a great portion of my healthcare career in the public sector, from 2005. I graduated in 2005 and left public healthcare in 2018. And the last 2 years have been in private. There are quite marked disparities between the public and private healthcare system. And that's something that I've noticed only recently since joining private healthcare. But if I talk about my junior years, just as Dr. Kanyile explained, being a young junior doctor is tough. It's rough. It's stressful. You're the hospital. You're everything. She mentioned being the porter to the patient's manager to the patient's best friend to everything, that you're just it. And the stresses that come along with that are indescribable, because not only are you dealing with patient stresses, you're dealing with hospital admin stresses, you're dealing with stress from your consultants who are having a bad day and want to know where's this blood result, and you've already spent your whole day looking for that blood result and you just can't find it. You're also still learning, you're trying to develop your skills, you're trying to go home every night and still read, but you still get in trouble every day for not reading. And then, as you go along the ranks, you become a registrar. I mean, it's stressful. You're meant to be involved in teaching, responsibilities increase, and then consultant and subspecialist. It feels like it never ends. There's a new era and a new stress and a new problem for each period of my healthcare career. And I think that's something that, a lot of us struggle with, just the transition with that.
And it is a problem because, according to this index, young professionals here in South Africa, amongst the 15 countries that were surveyed this year, are amongst the, in fact, are the highest stressed in the world. It's 82% or so of the physicians that were surveyed, according to this index, regularly experience work-related stress. And what the index has also shown us is that a lot of young people are rating a work-life balance quite highly, and in working in stressful environments that don't seem to have an end, it is causing young people to go and choose less stressful careers, and resulting in an exit of young professionals that we need to transform our future healthcare system, which presents a problem for us in future. And Dr. Coleman, I just want your view then on how hospitals and clinics can better manage the environment that a lot of doctors and medical professionals are working under strain themselves with limited resources, of course.
Cool. Thank you for having me, Fifi. I think, Fifi, at the outset, there is a system problem with the healthcare system, and it's not just resource constraint in itself. I think there's a policy problem and a regulatory problem, because we, in the healthcare space, and speaking for doctors and most healthcare professionals under the Health Professions Council of South Africa, we operate in legislation from 1974. Healthcare was very different then.
All right,
built for a very different demographic in society in Southern Africa. They've tried to chop and change, and those policy decisions are being led by retired, if not only academic, if not practitioners, are not in private practice. So the bulk of the policymakers are not involved in the system outside of their current systems. These are professors, these are academics, these are consultants, people who are at the top of the food chain or the top of the pyramid in healthcare, but aren't on the ground, as my esteemed colleagues have said, to know what happens on a day-to-day basis. Because the reality is, because there's such a large disparity in compensation between the public and private healthcare system, not everyone, but by and large, you actually get consultants who are in the hospital for a couple of hours and then shoot off to their private practices, which leaves the juniors, as my colleagues have mentioned, to hold fort and make critical decisions that they may not have adequate experience to make. So I think the solution lies in a revamp in the model, because, for example, our training in South Africa is a 6-year degree, and 2 years internship, and a 1 to 2 year community service. So these are compulsory years that the rest of the world doesn't need. The UK doesn't need an internship that long. The US doesn't need an internship at all, unless you're doing it in your particular field. And if you look at India, it's at a very similar space. A US medical degree and an India degree is 4 years, but a South African degree is 6 years, and then you've got your obligatory services, which is essentially where you're being milked because you're told that the system paid for you to graduate or fund your entire system. I think the policy needs to change. The perspective of healthcare needs to change from a consultant or specialist-centric system based on the way the regulations and the systems were built to a patient and outcome-based system, as our esteemed colleagues in the previous panel has mentioned. And that means focusing on finding that balance between what the system needs for patients, but also what the practitioners need. Because you will find yourself in an exodus, which these surveys have found now, in which many consultants either get frustrated with the 15 years it takes to qualify in this country as a specialist at least, or they're just going to leave and do other creative things like aesthetic medicine or do law or other practices, which is less stressful and more satisfying. So it is a policies problem, it's a compensation problem, and I think the opportunities and the timing now in a COVID world is optimal to relook at where the systems are. The HPCSA has just appointed a new board, and I think, again, which my largest frustration with that is the average age is closer to retirement than younger doctors, which is worrying. Because if you want agile thinking, you need people who are closer to the ground than the top of the pyramid in the system.
Yeah, no, certainly. Paul, just to get your view, perhaps to reflect on what some of your panelists have said, and also as one of the seniors in the panel, given your designation, I mean, why are a whole lot of young people in hospitals? We can speak generally, not finger pointing at Tygerberg specifically, but why are they being overloaded with all of these responsibilities that go over and above probably what is their KPI, and again, not being remunerated for such services? What's going on from a more senior point of view?
So, I mean, I can talk from a perspective of a hospital manager, and I mean, we have a system, as the previous speaker Terence referred to, which is structured in a particular way. The internship, for example, is statutory. It's not a system that's made up by the hospital itself. The registrar system, in terms of the usual duration being 4 years, etc. Some of them are even longer if you then subspecialize. That is also statutory. So, and of course, that means there's a hierarchy. And I think the problem, and Dr. Cornelia kind of referred to this earlier. If you work certainly in an urban, a big academic hospital, and not all interns do, and that's another discussion. You are in this hierarchy where an intern, I'm just talking about medical staff, and I think we need to be conscious that medical staff and the production of medical graduates really is only one aspect of a healthcare system. I mean, doctors have to work in an ecosystem of many other types of healthcare workers, and I think that we've been singularly uncreative in South Africa at looking at different categories of healthcare workers who can really benefit the healthcare system at much lower cost. But that perhaps is another discussion. So I think in terms of the experience that junior doctors have, whether you're talking about interns who are the most junior in the hierarchy, or you're talking about registrars who kind of sit in the mid portion of the hierarchy, it's very, very tough, and it's related to a whole lot of factors. I mean, interns and registrars qualify they work in the public sector with all the challenges that there are in public sector facilities in the country, and that's everything from quality of the building they work in, quality of the technology they have, availability of consumables, availability of PPE if you're talking about COVID, working hours. It's related to how many doctors there are, which dictates how often you're on duty on a roster. And then critically, there's organizational culture. How do the registrars treat the interns? How do the consultants treat the registrars? How do the consultants treat the interns? If you have a culture of, well, I did my internship 30 years ago and I sweated blood, so you're going to sweat blood, then you're going to have a toxic culture. And along with all the other problems, the interns are going to suffer even more, despite the fact that maybe the building's new and maybe the consumables are available, because they've got a toxic registrar or a toxic consultant who doesn't understand the life of an intern. And it can happen with registrars too. And often a registrar who's not treating an intern in a responsible and respectful way is himself or herself being treated badly by a consultant. So the organizational culture issue is really absolutely critical when you are working in the kind of hierarchical system that we have. I mean, I'm obviously only referring to medical staff. Ideally, interns should have, as I say, a healthy ecosystem of other healthcare workers around them that make their jobs doable, that make their jobs meaningful. Remember, it is a training post, so they're actually also meant to be learning. And I think that's also a kind of a psychology that I think Dr. Cornelia referred to, that interns are just kind of production units. They're actually trainees. They are not fully registered doctors yet. So, what I've tried to sketch is just the environment that I'm familiar with in an academic hospital. And interns can be working in very, very small hospitals, district hospitals, where they have another problem, which is the lack of senior people around them to supervise them. They can get presented with really, really catastrophic medical problems that they just have to handle themselves, because there's no one. They are the most senior person, and that's also a very, very difficult situation for them to deal with. And some people, I think, it really can be quite terrifying. And I'm a long way from the time that I did my internship. Obviously, Dr. Kanyile is much, much closer. So I hope that provides some perspective. So I think there are some absolutely critical basic things that need to be met to make the life of junior doctors at least tolerable, if not enriching. And they really, really should be.
Right.
I mean, yes, a medical degree is a very tough degree. It's a long, hard road anywhere in the world. You can ask the life of an American surgical resident, how tough their life is as well. You start surgery, you start cutting at 6:30 or 7:00 in the morning.
Right.
So it's a long, hard road, especially to become a specialist or a subspecialist. But we, as health system managers, need to make that road as smooth as we possibly can in a resource-constrained environment. And it is a massive challenge.
Yeah.
Thanks.
Right. Thank you. Thank you so much. I feel like I'm not observing protocol by calling you guys all doctors. So I'll just take the hint and get on board. So Dr. Nokukanya, in terms of the organizational culture, as Dr. Paul has said, a lot of the senior citizens will talk about, I went through this and this blood, sweat and tears that I went through as well, so don't complain because I did it and look at me now. It does seem that one of the areas that can help reduce a lot of the tasks, the time it takes to do the tasks and the stresses is technology. And I'm just wondering, in your view, as a young professional, are you finding the adoption of technology, or a lot the senior doctors in your workplace, are you finding them wanting to embrace the efficiencies that technology can bring to the work environment?
So to address the first point, I think it's incredible to understand the culture. If you look at the FHI, there were some statistics that came out where only 79% of people would consider a hospital's reputation when they consider a place to work as an intern, whereas 96% of them will consider the workplace culture. And I think that goes into, I've worked at Chris Hani Baragwanath, which is the largest hospital in Southern Africa. And we had the toughest time, but because all of us banded together and we all worked together, it made it an enjoyable experience that I never want to do again, but I really learned an incredible deal from. Going towards your second point, which is just with regards to all of this technology that we want to bring in. As junior doctors, we are so excited. We have apps on our phone, and I even speak to my students because I am a pediatric registrar currently working in the Johannesburg circuits, and I always speak to them and say, download these apps. Here are all these calculators that you have at your tools, and use 2 or 3 apps. You don't have to have every single one. That can really focus your learning and focus your patient management. But I find that a lot of my students feel overwhelmed because they just feel like they can't keep up with the information. But secondly, our seniors don't want to integrate all of that information. And those who do really are a niche section of people. And it's difficult to have continuity because as you move in internship from rotation to rotation, ideally you'd like in one hospital for there to be continuity in the system. But because we don't find that, because people are stuck in their ways per se, and also because technology is quite difficult to get a handle on, you have to have systems in place that are reliable. We need to be able to access patient results, as Dr. Yvette mentioned earlier. You know, you look for sometimes even hours for one patient result and still not find it. And then you also go to topics such as integrating that information with the other available systems that we have. That's a challenge that a lot of people are not willing to sit down and answer. And I think for us as junior doctors, there's some interesting apps that I've seen and young people who are coming up with just even simple things like integrating a ward work list, which is where any patient we admit them, we have all of these tasks and results that we need to follow up, and it's all in one space. It would be so great if we could integrate that across all of our rotations and also across all of the departments in the hospital, because it would make our lives a lot easier. But also, if our seniors will allow us, we would be able to integrate that into their teaching to make it easier for them to educate us.
All right. So that word, that interoperability of systems coming up again. I think this tonight I got it right. It is quite a tongue twister. But Dr. Yvette, to come to you as well. We were talking, actually, you and I before this panel, and you were also from the public sector. Now that you are in the private sector, and I was sharing my experience of some of my friends who are doctors who just go to the public sector to do their time and then ultimately leave. For better working conditions in the private sector, as it were, and also for better pay. Your view then on perhaps how the public sector can create a better working environment such that we don't see this skills brain drain from a really critical sector in our economy that is able to provide much more affordable healthcare than what is found in the private sector.
So to improve public healthcare is multifactorial. There's no one answer, there's no one solution. I think it's going to take everyone. It's going to take individuals, it's going to take healthcare workers, be it doctors, physiotherapists, occupational therapists, lab staff, the other people that work in hospitals, cleaning staff, admin, the security guards in the hospital. So there's just so many facets on how we can improve healthcare, and we can do it on a national level. So we can help the government, and the Department of Health can get involved. I mean, they've got a certain role to play. I think for them, good communication and communication with doctors, especially doctors on the ground, communication with other staff members, being present. I think to have people in management walking through the wards, hospitals, I really see that. Then also the other key players in hospital, one of the other panel members spoke about the fact that doctors are not alone. We don't make the hospital. It's cleaning staff, it's admin staff. We all make the hospital, and we all need to pull together. So I think there's corporate level and individual level improvements that can be made. There have been lots of improvements. We sometimes focus on the improvements that still need to be done, but we also need to pay credit to the major players that have improved, that have helped with infrastructure improvement. Also, I mean, there have been some technological advances in medicine. Some of our blood results are now online, x-rays, PACS systems, and those do help to create a better working environment. But I do think there is still a long way to go. Mm-hmm. Yeah.
Mm-hmm. No, I hear your thoughts. So thanks so much, Dr. Yvette. And Dr. Terence Comel, this is really fun. I'm really enjoying this. There's a question that has come from the audience watching. In fact, come from a panelist from yesterday's healthcare infrastructure panel as well. Linaya, thanks so much for tuning in today as well. It's the situation regarding the junior doctors. So as it reads, junior doctors are presented with a lot more complex situations than they are equipped to handle. And this is one area where digital health solutions that connect less qualified interns to more qualified consultants for advice and guidance could be helpful in bridging that reality of healthy personnel shortages. What's your view on this? I mean, are you seeing such digital services on the market around? Are you seeing uptake to use them also?
Thanks, Fifi. I think in the public health system, based on my understanding, because I do a fairly extensive amount of work with government, from a policy perspective, there is the district health system in which you have a centralization of some of the specialities in regional hospitals and districts in which you don't have specialities. So there is in theory, support system from consultants. The challenge with that is these consultants, senior doctors, registrars, or senior medical officers also have day-to-day responsibilities. So their incentive is to deliver on what they need to do in their primary roles, besides their secondary roles of supporting these district hospitals. You then have infrastructure kind of challenges, so connectivity, data, communication, electricity, and other infrastructure challenges, which become a critical issue. If you have an intern in a rural hospital who wants to connect to the main hospital and the doctor that he's supposed to is already in consultation, or he cannot get data, or he's expected to use his own cell phone, own airtime, and then look for signal when he can, it becomes difficult when he's got 140 patients to be seen for that afternoon. So practically, I think government has the thinking right from a policy perspective. From an implementation perspective, we don't have an infrastructure system that follows that model. I'm not saying it cannot be done. It has been done. We have a strongly supportive system. For example, the referral systems in some of the areas in KZN, using Nkosi Chief Albert Lutuli Hospital as a strongly digital system that is fed by King Edward and other facilities. You have a strong support structure, but a lot of that system and solution comes from the private sector and or grant funding. And I do think there needs to be a stronger push. If we focus on, as the previous panel spoke on, outcomes-based medicine and value-based medicine, there needs to be a remodeling of the system. At the moment, the current crossroads that we find ourselves in is the policymakers at the regulator, the medical council or the health professions council, is strongly populated by heads of departments or academics from the very hospitals that examine registrars and oversee the interns and their training. So you have a centralization of control and power of where healthcare and healthcare training comes from. Those who've moved on from the academic setting have now taken leadership positions in the colleges of medicine, because there's a large move to transform the institutions at the universities. So you're finding a range of academics that used to run the universities now actually run the colleges of medicine. For our listeners and viewers that don't understand the context, previously you could qualify with a Master's of Medicine or a fellowship from the college. Over the last couple of years, they've made it compulsory to do both, because the shift of academics from the academic institutions have moved to the colleges of medicine as a non-profit. I think there needs to be a review of the model, because you cannot have the decision-making powers, the training powers, and the control centralized to particular individuals in a vertical. There needs to be a horizontal approach of saying the trainer should not be the person doing the examining. Your accountability, as Paul had mentioned earlier, should be strongly from the management, and there needs to be an integrated model with management, because bulk of the assessments come from the system in which it is a vertical and pyramid system. That needs to change.
Okay. Dr. Paul, just your thoughts. There was a comment that was made, and I think it does relate to some of the internal barriers to transforming the healthcare environment, and that is that a lot of the comments and the ideas and the views of young people, junior doctors, are not necessarily taken on board. They are overlooked, as it were. And I just would like your view and your take on that, and how, as a more experienced healthcare professional, you are managing that. What is your take, and perhaps maybe some advice for young people who are coming out with fresher ideas as to how to improve efficiencies within your hospitals? How perhaps should they better communicate these ideas if they are being turned away at first go? If you could just unmute yourself.
Sorry. So health is an incredibly complex field, as I think the other speakers have alluded to, and we can only unfortunately just scratch the surface here. And technology and health is another massive topic on its own. So we are, first of all, we are cheek by jowl with Stellenbosch University Health Sciences faculty, and they try, and I think they do a pretty good job of being pretty much at the cutting edge with regards to at least being aware and at best integrating new technologies into their teaching programs. And we do our best from a hospital point of view to integrate the technology that we can, bearing in mind that we work within a much bigger system. So if you're talking about, what sort of voice do junior doctors have in a hospital such as the one that I work in, it's definitely one of the key competencies of a good hospital manager, particularly a public sector academic hospital, to listen to the ideas and the proposals that are coming from junior staff who will come in with ideas of different ways of doing things, introducing new technologies. And in a way, these are where systems came from, like, a previous speaker referred to the PACS risk system, which is a digital radiology system. At my hospital, we have an ECM system, which all this jargon, it's enterprise content management, which is a fancy word for basically digitalization of medical records. We have a lot of apps that have been introduced, which have actually been pioneered by junior staff. And these are apps that make the referral chain and the referral pathways much more efficient than there was previously. So I think that, this gets back to how do you govern your hospital? What structures and what processes do you set up to absorb ideas that are coming from staff, technologies that are being suggested? Do you have systems that are scanning the environment outside the hospital for new and emerging technologies? Because it's quite clear, and I think COVID has also been a lesson in this regard, that there are really quantum leaps that can be made in terms of quality of care and outcome for lower cost from absorption of technologies. Unfortunately, the state tends to be very, very slow, very ponderous. There is the crushing hand of standardization when you work in a huge apparatus like the state. So there's often resistance to the introduction of kind of upstart technologies, which often have very, very good internal merit, but they need to jump through so many hoops that you often find that the originators of the technologies get disheartened. I think in the Western Cape, the department that I work in, there's an openness to technology, and it is one of the big strategic thrusts of the department. Telehealth. I mean, I know all these terms and they mean different things to different people, telehealth and telemedicine, and there's mHealth, etc. They have massive opportunities, and a hospital manager worth his or her salt needs to govern the hospital in a way that the hospital is at least best positioned to absorb those technologies and to leverage those technologies and to make them available to the staff who need to use them. So, yeah, and I mean, we're not even talking in this particular instance about health technology as in very sophisticated medical equipment. And that is another kind of subject that we can talk about, because you also need to run a modern hospital, CT scanners and MRIs and learning accelerators and all of those very, very kind of big ticket items, as well as the more basic equipment.
All right.
Thanks.
All right. MRI. The jargon in the medical profession is it's quite something to grapple with. Can I play a devil's advocate here, Dr. Nogokanya, just to bring you in here, because there is also a perception, and this is not only in the medical space, this is all over, that sometimes young people don't have patience. We want to get there, and we want to get there now. And in as much as there is pushback, perhaps, to some of our ideas and how to make things better, perhaps there is also a little bit of patience that is required on our front to learn a lot more and to eventually get there. So to what degree is some of the challenges that junior doctors and younger doctors are experiencing the result of a lack of patience and the result of wanting to succeed today, as it were?
I completely agree. As junior doctors, we are not patient because we know the things that need to be done to help our patients. We know what needs to be done in terms of technology that can improve not only working environments, but patient outcomes. And I think that's an ode to youth. Every generation, be it the hipsters from back in the day, or even our generation who had to fight apartheid, my parents' generation had to fight apartheid, were at some point impatient with the system, and they had to force change to occur in some way or another. Thankfully for my generation, we don't have to use terms like violence and boycotts, etc., that are going to cause that change to happen. We can actually have conversations such as platforms like this one, where we can share our ideas with different population groups, different opportunities that we can open ourselves up to, and we can really get the key stakeholders that need to hear this information to provide that change. I think importantly to our junior staff, and I always say this to my students and my interns, if you feel that there's something that you want to change in the system, talk to me about it, but give me evidence. I think evidence for us as a young population is really going to be the tool that we need. And it's going to be the one thing that we have easiest access to drive change. Find the evidence in your environment and use that as an argument that you can take forward to your hospital management. And just to go on to value-based care, and I think it's something that is important that I bring up here. I think it's a difficult concept for us as junior doctors to wrap our heads around, because we've got such a huge system that is working against us. And now we're expected to have outcomes that are based on value for the patient, with systems where we have delayed operations, we have long waiting queues and waiting times, we have overstressed and overstaffed understaffed working environments. And so you get people regularly experiencing burnout. I think for value-based patient care, we definitely have to prioritize this. And I think as junior doctors, we are trained to do that. But don't be impatient with the system. Work in your environment, try to change what you can, and from there, we'll be able to make effective change for our futures.
All right. Dr. Yvette, there was a question that has also come from the audience. Perhaps you can also add a bit of color to it regarding the young professionals, a lot of young professionals, junior doctors leaving the public sector for the private sector. And there's a question whether this is as a result of it not being a safe environment to work in the public sector. Has this been your experience, or perhaps is this the experience of some of your fellow colleagues who potentially are still working in the public healthcare sector? If you could just unmute.
Sorry, so safety is very important. Being female, being a junior doctor to a senior doctor, safety, especially for female doctors, is very important. There are many public healthcare facilities where we work 24-hour shifts, and doctors need to go from one ward to the other. It's uncovered, you're walking in the rain, and there have been many incidences amongst my colleagues and friends that I know of, especially women, who have been assaulted or had cell phones stolen, handbags stolen, their cars broken into. So safety on call is very important. And we also, as young female doctors, we get a lot of flack from our family members, parents, spouses. They don't want us working in an environment that's not safe. But they also don't understand our working environment. I think also, so there's safety, there's an infectious disease risk. COVID-19 is not the first infectious disease that South African doctors have had to face. I myself have had tuberculosis, and I've had multiple needle stick injuries. So PPE, there's much hype about it right now, but PPE was important 10 years ago when I had tuberculosis with no N95 mask. And, sometimes you don't have the right sized glove to take blood, especially female doctors. I mean, we have very small hands. We don't have the correct size gloves. And lots of male doctors, they have bigger hands, no gloves. So I think safety in the workplace is important. And I do know many of my colleagues that have left public healthcare citing the reason of safety, but not just left public healthcare for private, but left public healthcare for international opportunities. And that is, I think that's going to be one of South Africa's biggest problems going forward, this mass exodus of skilled healthcare workers leaving South Africa, because I don't think anyone will disagree with the fact that South African doctors are amongst the best trained in the world. And to replace a doctor, be it an intern, registrar, or a consultant or subspecialist, with anyone from anywhere else is going to be an expensive process, and it's not going to be good enough.
Yeah,
I really feel that as a country, we need to pull together, and whoever are the policymakers need to really listen to the fact that doctors are leaving. and we need to find the root of their disgruntlement. And honestly, doctors, we're not high maintenance individuals. We go to work at public healthcare facilities. We go to toilets that don't always work. We walk around in the rain. We work 24-hour shifts. We don't eat. We don't see family members. We don't have Christmases. We don't have birthdays. We're actually quite low maintenance people that have genuine passion to help and to improve the quality of patients' lives.
Yeah.
And I really feel that we need to be heard with regards to better working environments.
Yeah, definitely. I agree. And you raise a very critical point regarding the skills flight, not only from the sector, but from the country, which is of concern, because we need all the talent that we can get, the best talent to reconstruct this economy. But I'd like us to go into closing remarks. And in our closing remarks, I'd like us to build the blocks, so perhaps put the bricks in place that we can and that the profession can start building on to create a more ideal environment in which we're able to retain as much talent as possible. And Dr. Terence, to begin with you, because I mean, you did mention quite a lot of challenges in the system as it is. You mentioned the fact that the entire education model needed to be revamped. You cited concerns regarding policy that also needed to be addressed, and an organizational culture, something that was mentioned by your other panelists. But so I would argue that some of the points that you have raised are things that may take a bit of time to change. It's not something that we can do overnight. And then I would ask then for your insights on what can we do overnight? What are the quicker wins that can be put in place today to create a more ideal environment that is able to retain as much talent in the healthcare sector as possible?
I think, Fifi, in summary, as I mentioned on previous panels, my view to finding quick solutions and quick wins that are sustainable is the AIR model, A-I-R. It means remaining agile in your thinking, in your conduct and actions. It is focusing on impact, which is quick impact and long sustainable projects. So whether it's, as my colleagues have mentioned, whether it's to your students or the registrars that you're training, or within the environment that you're working with through time and relevance. Is what I'm doing an improvement to the system for an improvement's sake, or is it genuinely going to add value to the patient and their outcome and their well-being? So we need to change our approach and perspective in how we handle healthcare from an individual perspective so that we can contribute positively and actively into the system. Because there are phenomenal technological advances, there are phenomenal solutions that are available. For example, Zebra AI, a radiology solution out of Israel, cost $1 per imaging, which is no human intervention, and you can get reports that are more accurate than one assessed by a radiologist. These technologies are easily available, they're easily accessible. Whilst we wait for the system to catch up, we can make it easily and more accessible to our patients, whether it be in the private system or the public system. And I think in the private system, you have a lot more access to creating access and showing best practices so that the state system can emulate some of those best practices and opportunities, whether it be with junior doctors or across the entire system.
All right. Paul, I want to come to you because in terms of as we wrap up the conversation and the building blocks to create a better environment, there's some of, more senior doctors like yourself, senior citizens who have been in the system, the healthcare system in South Africa for a very long time, having worked both in the public and also having worked both in or in the private sector as well. And the thought that has come out is the fact that our healthcare system isn't the same as it was, and it is unfortunate in their view. So perhaps as you do give us some building blocks that we can use to create a more enabling environment, draw from your experience of what used to happen previously and what can be drawn from the past to create a better future.
Fifi, that's a really, really big question, and I can really only just try and make a couple of remarks about it. I mean, I think at the end of the day, until such time as healthcare professionals are replaced by robots, and maybe that's going to happen at some stage, however good the technologies are, and they are fantastic, we still have a people-driven system. So, if we're focusing around health systems that require people of all kinds of different categories of healthcare workers, including doctors, to deliver services until we get the organizational culture right, until junior staff are treated appropriately and with respect by senior staff, until junior staff are properly mentored, until there are programs that look after staff who are struggling, until we have good orientation and induction and onboarding systems, we are going to struggle no matter how good the technologies are. And I mean, I agree with the comments that have been made that technologies can be pioneered in environments that are more agile, more flexible, and then can be imported or osmosed into the state system. So as I understand the main topic of this program, if we're talking about the training of doctors, and particularly junior doctors, we have to get the culture right, and the culture is across. For example, the organization that I work in, which has a very strong focus on culture, that's the Western Cape Department of Health. That goes across everything from community-based healthcare workers all the way up to the cardiac surgeons and the neurosurgeons, and all the systems and all the facilities that pertain.
Right.
So the old expression, culture eats strategy for breakfast. So you can have wonderful strategies in terms of technologies and all the new stuff that's coming at us. If you get the culture wrong, we kind of dead in the water. So it really is about building in the value systems that underpin a constructive and kind of positive organizational culture. And then junior doctors can thrive. But it's a long journey. And it's an ongoing journey. Thanks.
Yeah, nonetheless, one that we need to start embarking on, or maybe speeding up on. And there is another comment from the audience just regarding perhaps incorporating more values in the training system, and perhaps if this is done, it can also create a better work environment. Nonetheless, I'd like to get to Dr. Yvette, just your final thoughts, your takeaways for the audience here at the Future of Health Summit on, what can be done sooner rather than later to create an enabling working environment.
I think I'd like to focus on the individual. I'd like to focus on each of us. I think that we can each improve ourselves in a certain way, whether you're an 18-year-old medical student, a 40-year-old subspecialist, or a 60-year-old professor. There's something to learn academically to improve yourself and to improve the outcomes of your patients. There's also CPDs, academic things we need to focus on. We need to put more effort into these. We also need to put a little bit of effort into ourselves, into personal growth. Lots of doctors, we need to maybe spend a few more minutes with each patient. We need to maybe show that we care a little bit more, because we all do care, but sometimes it's difficult to show it. We need to be a little bit more patient with our patients. And I think if each of us as healthcare professionals in South Africa improve and better ourselves a little bit more, we can definitely improve the healthcare of South Africa.
All right. So are you taking a bottom-up approach there to the improvement of the entire system? Final thoughts from yourself, Dr. Nogokanya.
I just want to say, firstly, thank you again for this opportunity. As young doctors, I don't think we are heard enough, but I hope that we are listened to more in our environments. We're always taught a biopsychosocial approach when it comes to heading to our patients. Biologically, the body; psychologically, what it is that they feel about and experience about their illness; and then socially, the socioeconomic factors that are impacting. We can't change a majority of these. And as junior doctors, I think we have this expectation that we want to change the world. We are so optimistic and we just want to go gung-ho. And this is an ode to our seniors. I've worked in environments where we've been belittled, but I've also worked in environments where we've been really uplifted and motivated to learn. And in both those settings, it hasn't stopped my ability to work, but it has impaired on my motivation. And I find that with our seniors and even with our colleagues on the same level or junior to us, please remember that each person that you work with is a human being. And as Dr. Yvette said, we are individuals and we have different facets to us. So let us all take into account all of those different facets. And I promise you, your relationships with your patients will improve because you will see the human in them before you see the disease. And the same thing goes for our colleagues. Use the technologies around you. There are so many apps available. Speak to your colleagues about those apps, and you'll find that a lot of your patient care and also your value-based outcomes improve.
All right. Nothing further to add there, Dr. Nogokanya, and all the panelists. You guys have summed it all up. I'd like to thank you so much for your time in joining us here this evening. And just one last thank you from the panelists. That is Dr. Nogokanya Kanyile, who is the Vice President of Mental Matters, Dr. Yvette Lazarus, the specialist physician and rheumatologist at Morningside Mediclinic, Dr. Terence Kamal, founder and chairman and CEO of the Medical Expert Consulting Group, and also Dr. Paul Chiaparelli, the Chief Operational Officer of Clinical Services at Tygerberg Hospital. Thank you.